So first of all, I want to thank Dr. Kurtz for giving today's chair rounds. Dr. Kurtz is the professor of medicine at UCLA and the chief of our division, along with factor chair for molecular nephrology. It's a real privilege to learn acid base from him, and I think the fellows will have a wonderful hour coming up. If you have any questions, either unmute yourself or put it in the chat, and Ruth can navigate because I may be in and out. Okay? Ready?
Okay, thank you so much, Mandana. Thank you. So what I'd like to do today is go from the sort of very basics, the chemistry behind acid-base disorders, and then go to the clinical diagnosis of these disorders, and then from that go to some of the diseases and approaches that can affect the acid-base status of blood. So Ruth, can I have the next slide? Okay, so this slide shows the bicarbonate carbonic acid carbonate buffer system, which is the most prevalent buffer system in the body. And that's why the diagnosis of acid-base disorders focuses on this buffer system. We have many other buffer systems. We have a phosphate buffer system, albumin buffer system. There are many other buffers, but because bicarbonate and the substances that it converts to are the most prevalent, historically, over the last 50, 60 years, acid-base diagnosis has focused on the bicarbonate buffer system. Now, the way I'm going to present this is the so-called Boston approach, which evolved in the 1960s. It was Schwartz and Relman, if you want to look at the original papers, who came up with most of these concepts. I'm not going to talk about another approach to acid-base disorders, which is called the Stewart formulation, which evolved in the 1980s. And I have a number of different critiques of that approach also, but you might hear about it. It's very different than the so-called bicarbonate-centric approach. Now, there are two different bicarbonate-centric approaches: the Boston approach, which I said evolved in the 60s, and also another approach which sometimes you see on the blood gas analysis called base excess approach. I'm not going to be talking about that today also. If any of you have questions about that or would like to discuss that further, I'd be glad to do that separately. So just looking at the top of this slide, what you see is the bicarbonate buffer system, where carbon dioxide and water combine to form carbonic acid, which then breaks up into a proton and bicarbonate, and the bicarbonate can break up further into another proton and carbonate. Now, all these are present in the blood and our cells, and they're present at equilibrium throughout our body. So just keep that in mind, and also keep the terminology in mind. Bicarbonate only refers to one of these species. You have to remember the other terms in this equation: carbonic acid and carbonate. Bicarbonate is by far the most prevalent. It's 24, 25 millimolar. The carbonic acid and carbonate are in the micromolar range at equilibrium, so they're much smaller in concentration. Now, the next line says something different, and that is the TCO2, which represents the total CO2, and that's what you get back from your chemistry panel. You do not measure bicarbonate. There's no way to measure bicarbonate, actually. We measure the total carbon dioxide content of blood, and it is equal to bicarbonate plus carbonate plus carbonic acid plus dissolved carbon dioxide. So it represents 4 different substances, but by far the most prevalent is bicarbonate. So practically, clinically, when you get back the total CO2 from your chem panel, it basically is equal to bicarbonate, but it's a little more than that because there's also some carbonate there, carbonic acid, and the dissolved carbon dioxide is actually the most, other than bicarbonate. The dissolved carbon dioxide is 1.2 millimolar. So for practical purposes, the total CO2 is equal to the bicarbonate plus dissolved CO2. As I said, the carbonate and carbonic acid are only micromolar. So just remember that, because some people call that bicarbonate when they get the blood back, and it's not. Bicarbonate can only be calculated once you know some of the parameters in the Henderson equation, but it can't be measured. So the next slide shows a summary of or a modification of the so-called Henderson equation, where the proton concentration is equal to 24, which is a constant, times, if you can go back, Ruth, times the PCO2 over the bicarbonate. And the PCO2 represents what the lungs do, and the bicarbonate represents what the kidneys do. And numerically, you can see the right side equals the left side. The hydrogen ion, forget the units. The hydrogen ion concentration is 40 nanomolar, and that equals 24 over 25. Some people use 25, so I put it there for this, times 40, which is the PCO2, over the bicarbonate, which is 25. And this equation holds true whether you have an acid-base disorder or not. So that's something that confuses people. The right side always equals the left side. It allows you to check whether your numbers are correct. Now remember that the clinical lab measures the H concentration. It comes back as pH, and it measures the PCO2 with the PCO2 electrode on the blood gas machine. The blood gas machine calculates the bicarbonate. So if you're going to check the equation, it's always going to work because the bicarbonate's calculated. If you want to check the numbers, you have to plug in the TCO2 from your chem panel into this equation as a surrogate of bicarbonate, since, as I mentioned, it's mostly bicarbonate, and then see if the right side equals the left side. Basically, you're just checking the measurement values from the clinical lab. Okay, next slide. Now, as I said, the clinical lab measures the pH, which is the negative log of the hydrogen ion concentration. And it does that because thermodynamically, the negative log of the hydrogen ion concentration is thermodynamically more important than the hydrogen ion concentration. That's why it evolved. Plus, it evolved for a human reason that clinically, humans don't like to talk about nanomolar concentrations, which is what the hydrogen ion concentration is. You know, it's 100 times 10 to the minus, pH 7 is 100 times 10 to the minus 7 molar, which is a very small number with 7 zeros before the 100. So because humans don't like to deal with such small numbers, pH sort of evolved also clinically. But you need to be able to convert one to the other to check the equation that I just showed. So if you remember that 7 is 100, and then just keep taking 80% of the previous number. So 7.1 is 80 nanomolar, 7.2 is 64, et cetera, et cetera. It's a very quick way of converting the two mentally if you don't want to do it on your iPhone or a computer. Next slide. Now, the next thing to remember is that the normal numbers that we get in the blood are different than in a male and female. And we tend to always think of male numbers, that the PCO2 will be 40, the bicarbonate will be 25. That's not true in a female. Females run PCO2s that are slightly lower, like around 37. And the bicarbonate's also a little bit lower, it's around 23. And when women ovulate, the PCO2 can go down into the high 20s, low 30s. So it's harder to get a steady state in a female because you don't know, there's sort of dynamic changes throughout the cycle because progesterone drives the ventilatory center and changes the alveolar ventilation and then changes the PCO2 because of that. So, but in general, the average is sort of 37 in a typical female. Next slide. There are also arterial venous differences. Remember that many times you can just do venous blood gases and they're perfectly fine. But remember, the normal values are a little bit different. The pH is a little bit lower in the venous blood by 0.03. The PCO2 is a bit higher. Bicarbonate's a little bit higher. So the typical values in venous blood are 737, 43, and 26 in a male. And that becomes your new norm that you start with before you look at acid-base disorders. Next slide. Now, this difference between the venous and arterial system can be more than this. And it's been known for 40 or 50 years that it varies with your cardiac output. So the less your cardiac output, there's a greater difference between the venous and arterial blood PCO2. And in fact, people used to use this 40 or 50 years ago to assess what the cardiac output was clinically. If you want to know if someone has a low cardiac output, just get the venous and the arterial PCO2 and subtract them. And the greater that difference, the worse their cardiac output is. It's a very nice way, without doing any fancy tests on the ward, to tell whether someone's cardiac output is decreased. In fact, used to be used clinically more commonly than now. Now people don't even know about this. So if you just want to assess someone's cardiac output and you're very worried about it, you can just get an arterial and venous blood gas and subtract the PCO2s. And if it's more than 2 or 3 different, there's something wrong with their cardiac output, most likely. Next slide. So looking at this equation now, where the hydrogen ion concentration always equals 24 times the PCO2 over bicarbonate. And as I mentioned, this is true whether you have an acid-base disorder or not. So let's just look at the PCO2. The PCO2 is kept around 40, again in males, that's a male number, because the production of the carbon dioxide equals its excretion rate. So we're in a steady state as far as input and output. We make about 20 moles a day in our mitochondria in the Krebs cycle, and we get rid of that 20 moles a day via our lungs. And so we're in balance, and our PCO2 stays at 40. So it's only when we have an imbalance that our PCO2 changes. So for instance, if I decrease my pulmonary excretion of carbon dioxide, even though I'm producing it at 20 moles a day, my PCO2 will start increasing until I reach a new steady state. We don't usually have changes in the PCO2 because of production issues. I mean, there are some patients that are very febrile. They might have an increase in their Krebs cycle mitochondrial carbon dioxide production. And there are patients that are on another dialysis machine that really isn't used anymore, called the READY machine. It can generate a lot of carbon dioxide. But other than that, changes in the PCO2 are really due to changes on the output, changes due to pulmonary ventilation. Next slide. The kidneys control the bicarbonate. So the question is, what does the kidney need to do to keep your bicarbonate at 25? Well, the first problem the kidney has is that bicarbonate is freely filtered, and there's a concentration of 25 millimoles in every liter. And every day we have about 150 to 180 liters going through all our 2 million glomeruli. And so that's about 4.5 moles a day, which is about what's in a box of Arm & Hammer baking soda. So that's what's filtered through all the glomeruli. Push the button again, Ruth, it'll go to the little cartoon. And if nothing else was done, all the bicarbonate, if all the bicarbonate came through the glomeruli and nothing else was done, in about 4 hours, you would be peeing out all your bicarbonate and you'd have nothing left. It would go from 25 to 0 very quickly. So clearly that doesn't happen. Next slide. And the reason it doesn't happen is we have a proximal tubule cell which reclaims the bicarbonate. Press again, Ruth. And on the apical membrane, so the reclamation of bicarbonate by the proximal tubule cell is a little bit complicated. It's not direct. The first thing that has to happen is you have to have a sodium hydrogen exchanger, a protein on the apical membrane of the cells. And there's 8 of these, but the one that's in there is called NHE3. It's the 3rd type of sodium hydrogen exchanger. And we also have what is called a vacuolar proton pump shown below it. And those 2 things secrete hydrogen ions into the lumen of the proximal tubule. Next slide. And what happens is the protons combine with bicarbonate to make ultimately water and carbon dioxide. And the carbon dioxide and water actually enter the cell again because of a concentration gradient that was created by the generation of this stuff in the lumen. We generate a small concentration gradient of water and carbon dioxide greater than the cell, and they enter the cell then, and they enter on aquaporin 1. Aquaporin 1 is felt to also transport the carbon dioxide, not just the water. They get back in the cell, and in the cell, the reverse reaction occurs. It's catalyzed by carbonic anhydrase 2, and it forms a proton and ultimately carbonate. Next slide. Or next. Now the proton just recycles again on the NHE3 and the proton pump on the apical membrane. The carbonate then leaves on the other membrane on another protein that we call NBCE1A, and it transports 1 sodium ion and 1 carbonate. Now, when you look at that, you can see the sodium has 1 plus, carbonate has 2 minus. So this thing is actually transporting a net -1. called an electrogenic transporter because it's transporting a charge. It's not neutral. And because it's transporting a charge, it actually can sense the charge also. And because of that, the charge on the basolateral membrane, which is negative inside and positive outside of about 50 millivolts, it drives the transport of this stuff out of the cell. So there's a negative charge actually being driven by the membrane potential that's on the basolateral membrane. The membrane potential on this basolateral membrane is created by two other proteins. One, the sodium pump, which is it creates a charge, and also there's a potassium channel on the basolateral membrane, and a number of them actually that also contribute to the charge. Next slide. So bicarbonate gets in from the lumen to the outside via this very complicated process. Now, there's another thing that happens that tends to change the bicarbonate that the kidney also must look after. So the first thing is it must reclaim the bicarbonate as shown on the previous slide. But there's something else that happens, and that is every single day from our diet, we're actually generating hydrogen ions in the form of hydrochloric and sulfuric acid, around 50 milliequivalents a day. And if nothing else happened, those protons will be binding with bicarbonate, lowering it, in the same reaction creating carbon dioxide. Now we just get rid of the carbon dioxide with our lungs, so that's not a problem, but we would be lowering the bicarbonate all the time. Next slide. And after 2 weeks, you can do the math, you would have a bicarbonate of 0 also. So this has nothing to do with reclaiming bicarbonate. This is simply due to the fact that our diet is like a hydrochloric acid and sulfuric acid IV. And the protons there bind bicarbonate and would tend to lower it. And it's the kidney's responsibility to prevent that from happening that we'll talk about in a minute. Next slide. Now, different foods have different acid or base, which I didn't talk about, producing capability. So foods that make a lot of acids are cheeses, egg yolks, meat, fish, a little bit less. And then there's foods that actually make bicarbonate when they're ingested, such as spinach and raisins on the other side. So it really depends on your diet. But an average North American diet, unless you're a vegetarian or vegan, actually produces acid. Next slide. So we've got about 50 milliequivalents of acid coming in. The liver, by the way, is the organ that makes the acid. It pumps these acids into the hepatic vein and then into the inferior vena cava. Next slide. And the reason we're okay is because the kidney actually senses this and generates about 50 milliequivalents of additional bicarbonate. Now, this is in addition to what it reclaimed from the glomerular filtrate, the kidney is generating an additional amount of new bicarbonate to match the daily hepatic proton load. Next slide. Or next, just press again. And in this reaction, we just make carbon dioxide again, which we just blow off, so that's not an issue. But this generation of bicarbonate by the kidney prevents the bicarbonate from falling in the blood. So how does the kidney generate this additional bicarbonate? Next slide. It occurs again in the proximal tubule, and the kidney actually takes up glutamine into the cell. Next slide. Turns the glutamine into alpha-ketoglutarate, and the alpha-ketoglutarate then enters the Krebs cycle and generates 2 bicarbonate ions. So that's where this new bicarbonate is coming from. It's actually derived from glutamine, carbon skeleton on glutamine initially. And in this reaction, 2 ammonium ions is made. Now, as you get CKD and ESRD, the ability of the kidney to take up glutamine and convert it into new bicarbonate decreases and decreases. And that's why we get a metabolic acidosis in CKD and ESRD. It's because the kidney is not able to take up glutamine normally and convert it into alpha-ketoglutarate and ultimately bicarbonate. That process is diminished as your GFR drops in most patients. And that's the mechanism for the metabolic acidosis that we get. Now, the reason the anion gap goes up is a totally separate process, which we won't talk about right now. But this is the mechanism for the metabolic acidosis. Now, the important point is that in this reaction that generates new bicarbonate, we also make ammonium ions. Now, why is that important? Next slide. The reason it's important is if the ammonium that was derived from this glutamine metabolism were also transferred to the renal vein with the bicarbonate. Next, press again. The bicarbonate that we just made, that we need to match the acid load from our diet, would not be able to contribute to that because the bicarbonate would be consumed in the urea cycle. And the reason for that is urea is made from 2 bicarbonate ions and 2 ammonium ions. So if we sent all the ammonia that we just made into the renal vein, the bicarbonate that we just made would not be free to match the daily hepatic proton load from our diet. It would actually be taken up in the generation of urea. And basically all we'd be doing is turning glutamine into urea, and we would not be generating new bicarbonate that could be used for matching this 50 milliequivalents of protons that we need to use it for. So what happens is, next slide, it turns out that the kidney does not send the ammonia into the renal vein to be turned into urea. At least the majority of the ammonia it makes in this reaction, it sends out into the urine, which is great. Now, I won't talk about today how the ammonia gets transferred from the proximal tubule all the way to the urine. It's a very complicated story. But when you look at the numbers, about 60% of the total ammonia made goes into the urine, and about 40% goes back to the renal vein. So we do lose about 40% of the bicarbonate that we made from that reaction in the creation of urea. And that's unfortunate because we would have then more bicarbonate available to match our daily hepatic proton load. But we do free up more than 50% of it, so that some of that bicarbonate, 60% of it, is left free to match the daily hepatic proton load. And that's more than enough than we need to do that. Next slide. So that's how the kidney keeps the bicarbonate at 25. First, it reclaims all the filtered bicarbonate through that complex set of transport processes on the apical and basolateral membrane. And secondly, it generates around 50 milliequivalents of new bicarbonate to match the daily hepatic proton load. And it matches it. Some people make 30, some people make 60 or 70, depending on your diet. Okay, now let's switch topics now to clinical acid-base diagnosis. And the way we do this is, to make a diagnosis, you look at the bicarbonate or the total CO2. And you ask yourself the simple question: is it normal, elevated, or decreased? If it's decreased, then you have to think of 3 acid-base disorders that can decrease it, and then choose which one it is. So if it's decreased, it's either metabolic acidosis, which everybody thinks about, but remember, it could also be acute respiratory alkalosis or chronic respiratory alkalosis. Remember that the respiratory acid-base disorders we divide up by time. We don't divide them up by, we don't use the word compensated, and we don't use the word primary and secondary. We just divide them up by a temporal subdivision called acute or chronic. This is historic, but it's just something you have to do. So there are 3 possibilities as to why the bicarbonate fell. So the question is, how are we going to distinguish them? Now, some people might say, well, by the severity of the drop in bicarbonate. And that really is not a good way to do it. The way we distinguish which of the 3 it is we look at the decrement in bicarbonate, and we look at the decrement in the PCO2, and we ratio those 2. Because the ratio of those 2 is very specific for each of the 3 acid-base disorders. If it's metabolic acidosis, the PCO2 drops, the ratio is about 1.2 to 1 or 1 to 1. The fall in the bicarbonate is roughly equal to the fall in the PCO2. If it's acute respiratory alkalosis, the fall in the bicarbonate is about 1/5 of what the PCO2 fell. And if it's chronic respiratory alkalosis, it's about 1/2 of what the PCO2 fell. So looking at those ratios tells us the diagnosis. Now, if it's not any of the 3, we know by definition we have a mixed disorder. We know we have more than 1 acid-base disorder present. But if it is one of the 3, then it tells you which of the 3 it is. Next slide. The bicarbonate could also be increased. So if the bicarbonate's increased, again, it's one of these 3 acid-base disorders. It's either metabolic alkalosis or it's acute or chronic respiratory acidosis. Again, to distinguish the 3, we look at the change in bicarbonate from normality over the change in PCO2 from normality. And we just look at the ratio of those 2 changes. And again, each of these 3 things differs. So you have to memorize these 6 rules in order to quickly decide what the acid-base diagnosis is. Now, again, what I'm saying repeatedly is the change from normality. So you have to know what normal is. And the best is to know what your patient was before, to know what their normal numbers were before. Usually we don't have that, so we have to use the population mean of PCO2 of 40 and bicarbonate of 25 for a male, or 37 PCO2 and 23 bicarbonate for a female. You have to assume what the average is for the population. But if you have previous normal numbers from your patient, that's by far the best. It's the same concept as the anion gap. It's best to have a previous anion gap that's normal in your patient to see whether there's been a change in the anion gap, rather than assuming what the population anion gap is, 10 or 11, something like that. It's always better to know what it is in your particular patient. Next slide. Now, the other sort of interesting thing is there's a relationship between the bicarbonate and the PCO2 in the steady state chronically that follows a curve. So as I said, in chronic respiratory alkalosis, the ratio is 0.5. And in chronic respiratory acidosis, I said, is 0.35. But it turns out even within the normal range, if you look at a bunch of people that are normal, there's a relationship between their PCO2 and bicarbonate, because not everybody's 25 and 40. Some people are 42 and 26. And so when you plot all that, you actually get a slope of 0.4. So it's right in between the chronic respiratory acidosis and chronic respiratory alkalosis. What you can see is the curve flattens out as you go to higher and higher PCO2s. But the important point from this slide is just to remember that there's a relationship even within the normal range. We tend to simplistically pick one number of 25 and a PCO2 of 40, but that's not correct. If you take a bunch of normals, 100 normal people, they'll have slightly different numbers that have a slope of 0.4. Next slide. Now it's a little more complicated because we have a subdivision for each of these. As I said, the respiratory acid-base disorders we divide up temporally into acute or chronic. Metabolic acidosis, everybody knows we divide up by the anion gap. And don't forget metabolic alkalosis, we also divide up, not by anion gap, not by time, but by whether it's chloride resistant or sensitive. In other words, whether giving chloride corrects it or giving chloride doesn't correct it. And remember, it's the chloride that corrects it, not the sodium. If you give sodium with a non-chloride salt, like sodium acetate or sodium gluconate, you're not going to correct the metabolic acid alkalosis. You have to give chloride. And it doesn't have to be in the form of sodium. It can be choline chloride, and it'll correct it. So remember, each of these we further subdivide into 2. The nice thing is the acid-base rules that I showed on the previous slide, the delta bicarb over delta PCO2, doesn't matter which kind it is, other than the respiratory, of course, because by definition it differs. But whether you have a chloride sensitive or chloride resistant, the ratio of the 2 is 7 to 10. And metabolic acidosis, whether it's anion gap elevated or not, the ratio is around 1 to 1. Next slide. Now, what about the anion gap? Well, it comes from the concept that we have a bunch of cations, first of all, and a bunch of anions in our blood that are equal. Otherwise, we would be a battery, we would spark. So we have what's called electroneutrality, that all the sodium, all the positive charges, which remember includes IgG is positively charged, is equal to all the negative charges. And there's a bunch of organic anions that I'm not putting there. I just have OA minus, but the right side equals the left side. So if you want to simplistically take the sodium and subtract the chloride plus bicarbonate, you're going to end up with all the others, which you can lump into anions minus cations. It's just stuff that we're not measuring, but you could put all the other ions on the right side also if you wanted. So that the anion gap is equal to the remaining, you can call it unmeasured, but it's probably better to think of it as remaining anions minus remaining cations. And normally you get a difference of about 11. Now remember that albumin is a part of that. And for every change in 1 gram per deciliter of albumin, the anion gap changes by 2.5. So, you know, it's a pretty big, it's a component of that anion gap, because remember, albumin's negatively charged, net. It has a bunch of charged amino acids, but there's a net negative charge. And also remember that because albumin's charged, every time you change the pH, you deprotonate or protonate albumin, and therefore you're going to change the charge on albumin. So it's known that for every 0.1 change in the pH, the albumin, the anion gap changes by 0.15 because of the fact that you're changing the protonation of albumin. So remember that the charge on albumin is not fixed. It varies with the pH, and therefore your anion gap will change with pH per se. If you change the pH, you change the anion gap, whether you have a metabolic acidosis or not. Every time the pH changes, the anion gap will change, irrespective of an acid-base disorder. And that's true whether the pH goes up or down. When you raise the pH, you deprotonate albumin and you actually increase the anion gap. When you lower the pH, you protonate albumin, making its negative charge less, and you decrease the anion gap. So in fact, if you think about it, every time you have a metabolic acidosis, the anion gap is actually decreased by the pH effect, even though it's increased by having organic anions floating around. So in metabolic acidosis, you're always diminishing the anion gap, if you think about it, because of the protonation of albumin. Next slide. Now, the important thing to think about with anions is that there's a dynamic situation. We have anions coming into our body, and we have anions leaving in the urine. We have protons coming in, and we have bicarbonate, remember, being generated by the kidney to compensate for that. We talked about the bicarbonate generation being 50, but it can go up to 200 or 300 if you have a lactic acidosis. The kidney will significantly increase its bicarbonate generation from glutamine. It just starts taking up a ton of glutamine, making a ton of alpha-ketoglutarate, making a ton more bicarbonate. So it depends on the proton load. But the point is that when you have a proton load with an anion, like proton with lactate, proton with beta hydroxybutyrate or acetoacetate in ketoacidosis, it's important to realize that the proton space is different from the anion space. The anions tend to go much more into the ECF, where the protons are buffered 60% inside the cells. The anions tend not to go into the cells. So the anion concentration goes up a lot more than the bicarbonate fell, just from the volume of distribution, because the protons are distributed intracellularly, whereas the anions really only go up in the ECF. And you can calculate the bicarbonate space, or the proton space, with this equation if you want, and then you can use that volume of distribution to calculate how much bicarbonate you need to give someone to correct it. Because remember, the bicarbonate space also includes the intracellular space, so it's not just the ECF or not just the blood where you're giving the bicarbonate. You have to know that, because that's going to the extent the bicarbonate goes in the cells, it's not going to go up in your blood. But remember that the space the organic anions go into is much less than the proton or bicarbonate space. Next slide. So some people have this concept called the delta anion gap, delta bicarbonate. And the concept is that the current bicarbonate plus the change in the anion gap can give you the original bicarbonate. But that has a lot of assumptions in it, which I listed here. One of the assumptions is that you assume that the change in bicarbonate and change in anion gap are equal. And that's not true, because to have that occur, the volume of distribution of the proton load and the anion would have to be the same. And as I just mentioned, the anions go into a much smaller space. Also, you'd have to assume that the excretion of the anions is equal to the same rate as the bicarbonate generation, which is also an assumption. And as I mentioned, the volume of distribution of the protons is greater than the anions, and therefore the change in bicarbonate is going to be less than the change in organic anions. Also, the excretion differs. For instance, lactate, we don't get rid of very easily when you have a lactic acidosis, whereas ketones are excreted by the kidney very easily, and that's going to affect the blood anion gap level. The extent to which you can get rid of the anions in your urine will also determine the anion gap. You have to remember, you have a dynamic situation. It's not just the input, it's how much anions are being excreted in the urine, is equally important in determining what your blood anion gap level is. And people always forget that. They think there's just an input, but there's also an output. In ketoacidosis, you can excrete the anions very well, and that tends to counteract the fact that the volume of distribution is less. So the ratio of change in anion gap to change in bicarbonate fortuitously just happens to be close to 1-to-1 because of those two counteracting factors. Or in lactic acidosis, not only is the volume of distribution of the lactate only in the ECF, so it's lower, but lactate excretion is very low. So actually with lactic acidosis, the change in the anion gap can be 1.6 times the change in bicarbonate, and that's completely normal. Next slide. So to use that delta-delta formula really is overly simplistic, even though clinicians like to make you do that. There's a lot of assumptions there. The other is the urine anion gap to estimate ammonia concentrations in RTA or other situations is a horrible measurement. The normal is +20 to +90. And the thought is that when you have increased ammonia, it goes negative to -20, -50. But it's really poor. It's not quantitative. And also, if you look at that equation on top, the urine anion gap is not just equal to the ammonia, it's equal to the anions in the urine minus ammonia. So if you have a situation where you have increased organic anions like ketone bodies or D-lactate or hipurate, it can give you a much more positive urine anion gap, and it can mask there being a lot of ammonia in the urine. So because anions affect it, organic anions, and it's not quantitative, it's pretty useless as a measurement, even though you'll see it on tests. And clinicians may ask you to use it. I mean, the best would be to measure the ammonia. The problem is clinical lab never gives that back to us. I mean, even 50 years after all this stuff was figured out, it's hard to believe in 2020 you still can't get an ammonia measurement in the urine. You have to go through all these indirect things, which are basically horrible. They're useless. Next slide. So a better way of estimating the ammonia is the urine osmolar gap divided by 2. So first we calculated using this formula, which most of you know. And the osmolar gap reflects ammonium chloride plus other non-chloride ammonia salts. So if you take that difference between the measured and the calculated and divide by 2, that's a pretty good reflection of the ammonia concentration. And the normal is about 10 to 100, the gap. There are assumptions, though, with it. One, it assumes that all the sodium and potassium salts are 100% dissociated, and that's not completely true. Plus, you can generate ammonium bicarbonate with urease-containing organisms. That's not a problem. It'll just increase your ammonia result. But you have to realize that ammonia did not come from renal biochemistry. It came from this organism in the urine generating. And it can give you a high level, even though, and you might think, well, the patient is generating and excreting a lot of ammonia biochemically in the renal processes, and that's not true. Now, the other thing is that you can increase the measured anion gap by if you have methanol, ethylene glycol, or mannitol in the urine, and you're going to get a higher difference than you would otherwise. And it's not because of ammonia, it's because your measured has been increased by these substances which were not in your calculation. If you include them in the calculated ammonia or calculated osmolality, if you include them in the calculated osmolality, then you're fine. Then they subtract out. But if you're only going to have them in the measured, but not in the calculated, you're going to end up with a high osmolar gap that you think was from ammonia, and it's not. Next slide. So here's a patient, when we look at the numbers, the first thing we see is that we look at the total CO2 of 15. Remember, that reflects mostly bicarbonate. And the bicarbonate calculated, which we got from the blood gases, is 14. So that makes sense. It's one less roughly than the total CO2. And it's one less because remember, the difference is due to the PCO, dissolved carbon dioxide, which, by the way, is 0.03 times your PCO2. So 14 plus 0.03 times 28 is equal to 15. That's sort of the math that we go through. But at any rate, you can see that the total CO2 or bicarbonate's down. So that leaves us either with a metabolic acidosis or acute or chronic respiratory alkalosis. We look at the change in bicarbonate versus the change in the PCO2, and we see they're roughly 1-to-1. And so this is most compatible with a compensated metabolic acidosis. We then look at the anion gap and see, is it elevated or not? And so 95 plus 15 is 110. We subtract that from 131, we get 121. So our anion gap is up by about 10. So we would say that this is an anion gap type metabolic acidosis that's compensated. And this makes sense. The glucose is 600. It's likely the patient has ketoacidosis. But then the patient got saline, and we look at the numbers. The bicarbonate's about the same. The total CO2 is about the same. Maybe it went up a little bit. The renal function improved, so the patient was likely volume depleted initially and now is volume replete. But we noticed that the anion gap is now normalized. So how did that happen? The anion gap's normal. The metabolic acidosis was converted to a non-gap acidosis, and the severity of the acid-base disorder is roughly the same. Does anyone have any thoughts as to what happened to the anion gap? It can't be that the ketoacidosis shut off, because then the bicarbonate would have been increased or normalized. We have the same severity of the acid-base disorder, but the anion gap went away. Does anyone want to unmute and say what they think might be going on?
Hyperchloremic metabolic acidosis.
The metabolic acidosis was hyperchloremic, but why?
From the saline load?
Well, saline doesn't dilute the blood enough to do that. I mean, you'd have to do the math to get rid of the anion gap, and by diluting, no volume overload. So it's not due to the saline diluting it. But what did the saline do by normalizing the GFR? Anybody? So what the saline did is normalize the excretion of the organic anions. So instead of the organic anions building up in the blood because of pre-renal failure, the saline normalized the GFR and allowed the kidney to dump the ketone bodies. And so if you check the urine for ketones, you would find a ton of them, even though the blood has nothing. So that's a very important point. Again, getting back to the dynamic story here, that the anion gap in the blood is a reflection not just of the input of organic anions, but the excretion rate. And when you're and the excretion rate is very dependent on the GFR. So the more pre-renal you are for a given input, the higher your anion gap. And as your GFR improves, the anion gap is going to fall for the same production rate. Remember, the same production rate. And here, this patient is still producing the ketone bodies, but they're all being able to be excreted now. For, there's no buildup in the blood, and that's why the acid-base disorder converted to a hyperchloremic one. It's the same acid-base disorder. There's no diarrhea here. There's no RTA. There's no new cause for the metabolic acidosis. It just converted to a different pattern because the organic anions now can be excreted. So this is a very important point that we see all the time clinically. Don't start looking for another cause for an acid-base disorder. It's the same as the original one. Anyone have any questions about that? Okay, let's go to the next one. Okay, so this is a 25-year-old patient who was glue sniffing, and the total CO2 is 15. Again, bicarbonate calculated is 14, roughly 1 less because the PCO2, as I said, contributes about 1, which is 0.03 times 28. That's the total CO2 of 15. Again, the PCO2 is down by roughly with the bicarbonates down, so it's a compensated metabolic acidosis. We check the anion gap, it's 8. So this is a non-gap or same thing, hyperchloremic metabolic acidosis. Okay, we look at the urine pH, it's high. The urine anion gap is positive, but the osmolar gap is sky high. So from the urine osmolar gap, when we divide by 2, we would say that there's about 150 millimolar ammonia in the urine, which is high. But yet the urine anion gap is positive. So how can that be? Anyone tell me what's going on in this patient?
I mean, it's a non-chloride anion kind of amounting for ammonia excretion.
Well, why is the urine anion gap positive? I mean, from the urine osmolar gap, you would say there's a ton of ammonia in the urine, unless the patient was taking ethylene glycol or mannitol or something, but the patient is not. So from the, yes,
Yeah.
that's correct. So with glue sniffing, it generates hippurate, and the hippurate anion comes out in the urine. And remember, the urine anion gap is organic anions minus ammonia. So if you increase the organic anion concentration, you're going to make the urine anion gap positive. And even though you have a lot of ammonia there, it can look positive, and it'll mask the ammonia in the urine, and you only can tell that there's ammonia from the urine osmolar gap. So this is a patient with glue sniffing. The hippurate comes into the blood with a proton, and that's why the bicarbonate fell. It's hyperchloremic because the hippurate is excreted very efficiently. It didn't build up in the blood to raise the anion gap. So the hippurate comes out in the urine, so the anion gap is normal, just like in the previous case where the organic anions came out when we gave saline. So it's hyperchloremic in pattern, even though the generation is organic anion, elevated anion gap in type. Because the organic anions came out in the urine, we're left with a hyperchloremic pattern in the blood. In the urine, the organic anions are masking the ammonia in the urine, raising the difference between the two as far as the anion gap. So we can't really see the ammonia reflected there, but in the urine osmolar gap, we have our big clue that there's a ton of ammonia in the urine. And the reason there's a ton of ammonia is the kidney has increased its alpha-ketoglutarate metabolism to try to match the proton load. So the kidney is making a ton of new bicarbonate from that reaction. And in the same reaction, it's making a lot more ammonia that ends up in the urine. Much more than it normally makes. The 50 milliequivalents a day that it normally makes, it's now making a lot more. And the urine ammonia is just a reflection of the significantly elevated new bicarbonate generation from alpha-ketoglutarate, where ammonia is made as a byproduct of that reaction. Next slide. Okay, so this is a male who was vomiting. Bicarbonate's elevated, 35, calculated 36 on the chem panel, the total CO2. And so again, elevated bicarbonate, it's either metabolic alkalosis, acute respiratory acidosis, or chronic respiratory acidosis. Remember, when it's elevated, there's 3 choices. When it's down, there's 3 choices. And you start your acid-base analysis by looking at the bicarbonate. Don't look at the pH. Do not look at the PCO2. You're wasting your time if you do that. Just look at the bicarbonate and decide, is it up, down, or normal? So it's up. So could this be metabolic alkalosis? Well, again, the ratio is 7/10. For every 10 increase in the bicarbonate, the PCO2 goes up by 7 as a compensation. Remember, there's a compensation in metabolic alkalosis also. There's not just a compensation in metabolic acidosis. In metabolic alkalosis, there's one also, except the PCO2 doesn't go up quite 1-to-1. It's 7/10 or whatever the bicarb went up, and that's what happened here. The PCO2 went up likely from 40. We're assuming it's 40. We don't know for sure. It's a male. We're assuming it's 40 from the population almost. And it went to 47, as we would expect, to compensate for the 10 increase in the bicarbonate. So what's going on here? Next slide. So when we vomit, we actually generate bicarbonate in the gastric vein. And the reason we do that is in the lumen of the parietal cells of the stomach, there's a proton potassium ATPase that secretes protons into the lumen in exchange for potassium. That's how we acidify our stomach. But when we vomit, that increases much more. And in that reaction, in the cell, that's coming from carbonic acid. And so we generate, for every proton that's secreted, we actually generate 1 bicarbonate ion. And that bicarbonate doesn't stay in the cell. It actually leaves the cell on a protein called AE2, or anion exchanger 2. And that bicarbonate then ends up in the blood, in the gastric vein, and goes into our body. And that's where, that's the source of the bicarbonate. Next slide. But we have to ask the question, why doesn't the kidney just excrete that bicarbonate? It's all filtered. Why doesn't it just come out in the urine? Because normally, if I just started a bicarbonate IV on you, started intravenous bicarbonate, you would just pee it out. It's very hard to raise the bicarbonate just from a source of bicarbonate. So other things are happening, when you're vomiting, other things are happening in the kidney that prevent the kidney from getting rid of this gastric bicarbonate load. One is the GFR is down because you're volume depleted, you're pre-renal. Secondly, the proximal tubule is hyperabsorbing bicarbonate because angiotensin II goes up in this volume depleted milieu, and angiotensin II stimulates a number of those transporters that I showed you on the second or third slide of how bicarbonate's absorbed and increases their efficiency. And then thirdly, as I'll show on the next slide, a protein called pendrin, which is in the cortical collecting duct, doesn't work as well. And so bicarbonate secretion, which normally is occurring in the cortical collecting duct, is decreased. We don't secrete as much bicarbonate. Next slide. This is a slide of the cells in the cortical collecting duct. We won't get into all of them, but I want to show you the last cell on the bottom, which is the bicarbonate secreting cell. And what happens is bicarbonate is normally secreted by this cell into the urine in exchange for chloride via this protein called pendrin, PN. But in order for it to secrete bicarbonate, there has to be chloride in the urine, in the lumen. And when you're vomiting, you decrease the amount of chloride in the urine. It's all absorbed, a lot of it's absorbed proximally. And so because there's less chloride in the lumen there, pendrin stops working and we can't secrete bicarbonate as easily, and therefore bicarbonate builds up in the blood also. So this is sort of the third reason we don't get rid of the bicarbonate load from our stomach. We just can't secrete bicarbonate normally. Next slide. This is a 62-year-old with heart failure on Lasix. Again, the bicarbonate's elevated, this time about roughly 8 milliequivalents per liter. Is this metabolic alkalosis, acute respiratory acidosis, or chronic respiratory acidosis? Well, the PCO2 is up again about 7/10 of what the bicarbonate went up. So this is only compatible with a compensated metabolic alkalosis. So when we have a metabolic alkalosis, we want to say, is it compensated appropriately or not? This is compensated appropriately, but we divide it up into two types, not by anion gap, not by time, but by whether the patient will respond to chloride. Now, we have a clue clinically as to whether the patient will respond to chloride by measuring the chloride in the urine. If the chloride in the urine is normal, then the patient will not respond to giving chloride. We can give as much chloride as we want and nothing's going to happen. This bicarbonate is going to stay at 33. However, if the urine chloride was low, that predicts for us what will happen clinically when we give chloride intravenously. And so because the urine chloride here is normal, you can give as much chloride as you want, nothing's going to happen. So this is a chloride unresponsive or non-responsive metabolic alkalosis. Next slide. Here's a 60-year-old male, bicarbonate's elevated, it's 34. Again, is this metabolic alkalosis or acute or chronic respiratory acidosis? Well, the PCO2 is 72, and what you can see is that the PCO2 is up roughly 10 for every 3.5 elevation in the bicarbonate. These numbers are only compatible with a chronic respiratory acidosis. They're not compatible with the other two acid-base disorders as a cause of an elevation of bicarbonate. So the patient has a chronic respiratory acidosis. Whenever you see that, right away you need to calculate the A gradient to determine the mechanism of the chronic respiratory acidosis. Because if this is a patient with chronic bronchitis, the A gradient is normal. Whereas if it's a patient with emphysema, the A gradient's elevated. So it's a very quick way of telling what's going on with the chest X-ray and also pathologically what's going on in the lungs. So whenever you have a chronic respiratory acidosis, immediately calculate the A gradient, which is 150 on room air minus 5/4 of your PCO2, which here works out to 60. So this patient has a sky-high A gradient. So this is not compatible with chronic bronchitis. The patient most likely has emphysema, some parenchymal lung disease. Next slide. Now, remember, the reason the bicarbonate goes up is it goes up temporally. If I step change the PCO2, step it from 40 up to some new value, and follow the bicarbonate over time in the blood, it goes up slowly over days, but will reach a new steady state after 4 or 5 days. At that point, we call it chronic respiratory acidosis. The initial point, where it's only up a little bit, we call that acute respiratory acidosis. We don't have a name for everywhere in between. So we have a name for the beginning, acute respiratory acidosis, and we have a name for the end when it reaches a new steady state. We call that chronic respiratory acidosis. And the reason we distinguish these two is the PCO2 is the same. For the same PCO2, we have a different bicarbonate depending on what day of the week we came and measured it. So that's very important to realize, is we have a dynamically changing situation here. And I won't get into the renal mechanisms that cause the generation and retention of that bicarbonate. That's really a separate topic. Next slide. And again, when we have a chronic respiratory acidosis, we want to distinguish whether we have the blue bloater chronic bronchitic patient or the pink puffer emphysematous patient, because it's the pink puffer that has the elevated A grade. Next slide. So here's a patient who's 78 with shortness of breath and bone pain. So we look at the numbers. The BUN's 80, creatinine's 3, so there's some renal failure. The patient's anemic, the calcium's elevated, there's bone pain. So right away, your brain's thinking myeloma. We look at the acid base. We've got a bicarbonate of 35 and a PCO2 of 70. Again, what causes the elevated bicarbonate? It's only metabolic alkalosis or acute or chronic respiratory acidosis. We look at the delta PCO2 and compare it to the delta bicarbonate. And we see we have a ratio of about 10 to, again, 3.5. So again, this is only compatible with the chronic respiratory acidosis. And the PO2 is 50. So again, we've got an elevated A gradient. So this patient has something else, something going on in the lungs. Next slide. This is a 24-year-old third trimester, bicarbonate's 14. It's either metabolic acidosis or acute or chronic respiratory alkalosis. We look at the change in PCO2 to change in bicarbonate. We see the change in PCO2 is roughly twice the change in bicarbonate. This is only compatible with a chronic respiratory alkalosis. Remember that pregnancy is the most common cause of chronic respiratory alkalosis. Well, actually, probably living at a high altitude is the most common cause. Pregnancy is probably next, and then chronic liver disease, which we have a lot of here at UCLA on the liver kidney service, is probably the third most common cause. Again, progesterone is what's driving the ventilation, most likely here and also in chronic liver disease. Next slide. If you look at the temporal changes, it's sort of the opposite of what I showed a minute ago. If you step down the PCO2 and follow it over days, it gradually decreases until a new steady state is reached. We have a name for the first part. We call that acute respiratory alkalosis. We have a name for the end called chronic respiratory alkalosis. We don't have a name for the middle. Next slide. Here's a 36-year-old male with anxiety. Bicarbonate's down a little bit. It's either metabolic acidosis, acute or chronic respiratory alkalosis. Look at the PCO2, look at the bicarbonate. The changes there are only compatible with acute respiratory alkalosis. They're not compatible with metabolic acidosis, where the changes would have to be equal. And they're not compatible with chronic respiratory alkalosis, where the PCO2 would have had to have fallen twice as much as the bicarbonate fell. This is only compatible with acute respiratory alkalosis, is what you'd expect with anxiety. Next slide. And again, it's important to realize that acute and chronic respiratory alkalosis do not require organs. They're simply reflections of changes in the bicarbonate buffer reaction. So whenever I drop the PCO2, I shift everything to the left, and that's why the bicarbonate drops. And conversely, if I raise the PCO2 acutely, I shift everything to the right, and I generate some bicarbonate. So just remember that the acid-base changes with acute and chronic respiratory alkalosis are not due to the kidney or an organ. They're simply due to changes in the equilibrium of the bicarbonate buffer reaction, and you do not need a body for that to occur. When I open a bottle of Coca-Cola, the same thing happens. It's no different than acute respiratory alkalosis. Next slide. For mixed disorders, there's some clues. You can have a mixed disorder when you're not in a steady state. When I showed those graphs over days, in the middle, you're not in a steady state. It looks mixed. There are other clues, though, that you have a mixed acid-base disorder. If you take the delta anion gap and add it to the current bicarbonate and get a number greater than normal, that suggests you have a mixed disorder. You can also have normal acid-base numbers. So the PCO2 can be 40 in a male, bicarb 25. But if you have clinical causes that suggest more than one acid-base disorder, you have acid-base disorders, even though your numbers are completely normal. And also, remember, when you don't have the normal compensation in metabolic acid or base disorders, so when you don't compensate normally in metabolic acidosis, by definition, you have a respiratory acid-base disorder in addition. And same with metabolic alkalosis. If you're not compensating appropriately, by definition, you have a respiratory acid-base disorder in addition. So the lack of an appropriate compensation in metabolic acid-base disorders, by definition, means you have a respiratory acid-base disorder also. Don't ever forget that. Next slide. So here's a 70-year-old male who's vomiting with end-stage renal disease. And look at the acid-base numbers. They're completely normal. pH is 7.4, PCO2 is 41, bicarbonate 25. You look at that and you might say, there's nothing going on. But if you look at more deeply, first of all, the patient's hypokalemic, so it says there's something a little bit going on. But what about the acid base? Well, calculate the anion gap. The anion gap is 20. So the patient has an elevated anion gap by 10, and yet the acid base numbers are all normal. How can that be? Well, you have to look at the clinical causes for clues. Vomiting should cause a metabolic alkalosis. End-stage renal disease should cause a metabolic acidosis with an elevated anion gap, which we see. We see the elevated anion gap. Why don't we see a change in the bicarbonate? Well, in this particular example, quantitatively, the vomiting raised the bicarbonate by the same extent that the end-stage renal disease decreased it. So you end up with complete normality. So remember, you're only seeing a reflection of the net of multiple acid-base disorders if they're present. And if they're equal in magnitude, but opposite in direction, your numbers can be completely normal. So don't be fooled. This could be a question on your renal boards. Don't look at those numbers and say the patient doesn't have an acid-base disorder. In fact, this patient has two separate acid-base disorders, which are equal in magnitude, but opposite in direction. And so the bicarbonate ends up being normal. Next slide. I think this is the last slide. So this is a 33-year-old male who is on Lasix. The bicarbonate's elevated, so it's either metabolic alkalosis or acute or chronic respiratory acidosis. The PCO2 is elevated. The change in the PCO2 versus the change in bicarbonate is only compatible with compensated metabolic alkalosis. It's not compatible with acute respiratory acidosis or chronic respiratory acidosis. So the patient has a compensated metabolic alkalosis. The patient also looks like they have a bit of pre-renal failure. BUN's 50, creatinine's 1.2. And then the patient developed shortness of breath. And the PCO2 went to 67, increased by 20. Bicarbonate went up a little bit. And if you look at those changes, the changes now from 40, the normal is 47 and 34. So from the change in the PCO2, which is 20, and the change in bicarbonate, which is 3, those numbers are only compatible with an acute respiratory acidosis. So this patient now has a mixed acid-base disorder. The patient has metabolic alkalosis, which they had, plus now acute respiratory acidosis. Next slide. Oh, one. So this patient is a 70-year-old with chronic bronchitis, diabetes, chest pain, complicated patient with crackles and edema. The patient has a PCO2 of 63 and a bicarbonate of 21. So they're right away, they're opposite in directions. You know, there's something mixed going on. The chronic bronchitis should be raising the bicarbonate, right? And the PCO2 is up by 23. So the bicarbonate should be up by, you know, 8 or 9, 7, 8 or 9, something like that. And why isn't it? And so there must be something else in addition to the chronic respiratory acidosis. Well, let's look at the anion gap. The anion gap is 137 minus 115, which is, you know, 22 or so. So the anion gap is up by 10. So this patient has not only a chronic respiratory acidosis, but an anion gap metabolic acidosis. The net is to decrease the bicarbonate because the effect of the metabolic acidosis on lowering the bicarbonate exceeded the effect of the chronic respiratory acidosis to increase the bicarbonate. So quantitatively, the bicarbonate falls a little bit from normality. So this is an example of a mixed acid-base disorder. In addition, which you can know right off the bat because the PCO2 and bicarbonate are going in opposite directions. That you never see in a simple disorder. So that alone is your clue. I think that's the last slide. Go to the next one. Just
Yes, that's the last one.
Okay. So that's it for today's talk. I hope from that what you learned was some simple chemistry first of all, and then how to approach the diagnosis of acid-base disorders. Look at the bicarbonate and decide if it's up, normal, or decreased, and then how to diagnose each one, some of the physiology behind each of them, and then the mixed disorders. And again, the way to do this for your boards is just every case you see, make sure you commit yourself to a diagnosis on paper, and don't be lazy about it, and also be complete. Remember to divide all the disorders up by two different types, and in the metabolic acid-base disorders, don't just look at the compensation, also look as to what the anion gap is, and when you have metabolic alkalosis, to look as to whether you predict it's going to be chloride sensitive or chloride resistant. And remember some of the subtleties of measuring ammonia. The urine anion gap is useless. If you want to assess it, use the osmolar gap divided by 2. Next slide. Oh, and that's it. So we'll stop there, and if you have any questions, be glad to answer them. Or afterwards, if you would like, you can just email me. Does anybody have any questions? Okay, well, we'll stop there then. Thanks a lot. Talk to you soon.
Thank you, Dr. Kurtz. Have a great day, everybody.
Bye. Bye-bye, everybody.